Welcome to the Roots of Research, where we go behind the publications and dig deeper with the movers, shakers, and rainmakers of Georgia Southern University. I'm your host, Dr. David Weindorf, and today I have the honor of talking with Dr. Bettye Apenteng, a professor of health policy and management in the Jiangping Su College of Public Health. Now, Dr. Apenteng earned her Bachelor of Science in Neurobiology, as well as a second degree in Individualized Studies with a public health emphasis from the University of Washington in 2008. She went on to complete her PhD in Health Services Administration and Policy at the University of Nebraska Medical Center. Her research centers on healthcare infrastructure, particularly in rural communities, and she's especially interested in the relationships among healthcare organizations and how they influence system capacity and performance. Since joining Georgia Southern in 2013, she has explored these topics through numerous federal and state grants and has an impressive publication record. Welcome to the show, Bettye.
Thank you so much, Dr. Weindorf. It's a pleasure to be here.
Oh, we're really excited to have you. Something that immediately stood out to me when preparing for this interview was how your research is both broad and incredibly detailed, studying the inner workings of healthcare systems from multiple angles. Was there a specific moment or experience that made you realize you wanted to focus not just on medicine, but on how the entire system works?
Yes, absolutely. I will start by saying that my 8-year-old self will look forward to me today and be surprised as to where I am today, but she certainly will not be disappointed. I did start off with an interest in medicine. I actually started my academic career in this particular field, but I did transition to neurobiology when I moved to the United States. And it is during that time at the University of Washington in Seattle that I got exposed to research through the neuroscience program. But halfway through my undergraduate studies, I was lucky enough to take a medical sociology class. And that class did such a great job of exploring and revealing how the political structures, the sociocultural context, the economical factors really shape health and wellness on a global scale. And I think it was at that point that I realized that to be able to effectively address health and wellness, sometimes there are constraints. And those constraints are often beyond the control of the individual healthcare provider. And so for me as an individual and as someone who was really interested in shaping health and wellness, I felt my impact may be greater looking at things from a population health management perspective versus that patient to doctor kind of relationship. So after that class, I signed up for a second major in public health. That is where my public health story began. I have not looked back since then. I moved on to the University of Nebraska Medical Center to do my graduate studies, where I focused on health services, research, administration, and policy. And as a health services researcher today, I would say that that particular pathway has allowed me to combine my newly discovered passion and dare I say destiny in focusing on population health management, my love for research with my original dream of becoming a medical professional. It's somehow aligned all three into a purpose-driven career that I'm incredibly proud of.
That's amazing. And to know that it harkens all the way back to your 8-year-old self, that is amazing. That little girl is super proud of you today,
Well,
I guarantee.
thank you.
Absolutely. Now, you've seen both sides, the science and the structure. How has that shaped your understanding of what makes a healthcare system thrive?
That's a big one. That's a big question. I will say that what I have come to learn through a lot of work that we have done through the Center for Rural and Public Health Research and Practice here at the Jiangping Su College of Public Health, I will henceforth refer to as the center. It's a little bit of a mouthful, but a lot of the work that we have done at the center, engaging directly with rural health organizations, including rural public health organizations, has really led to the realization that you cannot think about science outside of structure. of course, we're scientists. I'm a scientist, so I definitely advocate for integrating evidence-based guidelines, scientifically driven processes into how health systems operate. But if we do that integration without context, oftentimes it tends not to be effective. So what we do with the hospitals that we work with is really try to understand the context within which they are operating, the regulatory pressures, the economic pressures, the market-driven pressures that influence how they operate, how they are structured, and incorporate that into a tailored process to be able to kind of bring science in a way that works for that organization. And that's really exactly what we do in translational research, which is a lot of the work that we do, is basically taking the science and applying it in a way that is contextually sensitive and driven in a way that basically matches the needs of the healthcare system, but also what their preferences are. A good example that I usually give to kind of describe this is when you think about technology, usually the brightest and best scientists, computer scientists, software engineers, they come up with incredible technological things that have amazing capacities. But if there's no utility to the end user, usually all of that good stuff, we can't really harness the potential. So it's very similar when we think about science as technology, just using that as an example here. If we do not make it to have high utility to the end user, to the health organizations or the health systems, we're not going to be able to get that optimal response and outcomes that we're looking for.
So really thinking about like real world impact of what we're trying
Absolutely.
to do here. Yeah,
Absolutely.
that's fantastic. Well, our listeners will know that we're coming to you live today from Statesboro, Georgia, obviously a rural community here in Georgia. And a lot of your work focuses on rural hospitals and health systems. Can you talk a little bit about some of the unique challenges that we face in those communities and which hospitals in urban areas may not?
Absolutely, yes. So the rural context is distinct. It's distinct in a lot of ways from the urban context. Some of the things that drive those differences has to do with the population and the population demographic makeup. So as you all know, rural communities tends to be more older than urban communities. Well, what that means is that economic participation rates naturally would be slightly lower. It also directly impacts economic development in terms of the types of industry that are available in those communities, or whether they are actually diverse industries even to begin with. That really drives a lot of socioeconomic constraints that tends to impact the success of any entity, any business entity, and healthcare kind of being one of those, right? So when you think about rural hospitals, they are operating within these constraints. The population size in urban communities tends to be significantly larger than rural. They can sustain the operations of a hospital. If you have a rural community of 2,500 people, there is just so much that the hospital can do. So that means that the scope of their services, the scale in which they're operating is at a much lower level. Well, that ends up being a double-edged sword because community members don't get all the services that they need from the hospital. So they tend to out-migrate or go to other communities to seek their health care. So what happens? The small population base that the hospital had to work with in the beginning is even more dwindled because out of the 2,500, a significant proportion are seeking care elsewhere. That directly impacts the financial sustainability. And this is really a lot of the story that we're seeing across rural communities nationwide that really kind of underline some of the closures and the financial pressures that we're hearing for rural hospitals specifically in this nation.
Absolutely. You know, my wife is an occupational therapist and has worked in some rural settings before, and she's talked to me about the idea that some of the specialties, you know, that larger urban hospitals have, burn centers and maternal care and those kinds of things, those are really challenges sometimes in rural settings.
Absolutely. They are. And part of what makes that even more difficult, aside from just not having the the patient base is the lack of, or the difficulty in recruiting and retaining healthcare professionals into rural communities. And part of it is just kind of amenities. I mean, whether they're shopping, whether my spouse will find a job if I move here. The other is just because of that lack of volume, providers don't have enough to grow in their profession. Think about a surgeon. Surgeons kind of perfect their skill with volume. In a rural community without that volume, they don't have that training, opportunities. And so all of those constrain the ability to recruit specialists. And then there's reimbursement from a policy standpoint. Rural hospitals get reimbursed at on average lower, really, than their urban counterparts. And that is in part, again, driven by the population makeup that we talked about, some of those socioeconomic challenges that drive higher uninsured rates in these communities. So they don't have a big commercial base. The commercial payers tend to pay a little bit more. And so the hospitals, from a reimbursement perspective, are not getting as much as their urban counterparts are getting, given this differences in payer mix.
It is a challenge. It really is. Well, one of the things I want to have our listeners take a peek behind the scenes on is this wonderful opportunity that you and I had this past summer. This was so much fun. Bettye and I had an opportunity to go to Ghana this past summer. We spent some time there on a research project with broad implications for a variety of different reasons. I'm going to let you talk about that. Tell our listeners a little bit more about that project, and how did you really establish these research partnerships in Ghana?
Oh, yeah, that was a wonderful time, wasn't it? It was amazing to be able to go back to Ghana, be able to engage with such great people, connect with such wonderful and welcoming rural communities that we had a privilege to work in. This trip was part of that Ghana Study Abroad program, or at least it was embedded into that program. And the relationships that we fostered to make this trip happen has been many years in the making. As you know, the Ghana Study Abroad program was originally developed in the College of Public Health by Dr. Apenteng of blessed memory. And he was instrumental in really setting up and formalizing this institutional partnership that we have with the Kwame Nkrumah University of Science and Technology, popularly referred to as KNUST. And so myself and our team, Dr. Opoku from the Jim Pinchot College of Public Health, Dr. Gato from the College of Science and Mathematics, we have had big shoes to fill. And we have tried to step into these shoes and worked hard to expand the program in hopes of sustaining the program in the long term. And part of what we're really proud of is how we have reimagined the program a little bit to really highlight the research piece of it, to integrate those research skills for our students to be able to get on a global health scale. And so what we have been doing for several years now is really, and in collaboration with our Ghanaian partners, is looking at non-communicable diseases or chronic conditions, trying to understand the risk factors, the mitigation factors, how to prevent, how to manage these conditions within that low middle income, particularly the Ghanaian context. And our hope is to look at this from a very holistic perspective so that we can understand the things that intersect or interact with one another to shape kind of these outcomes. And so we've been picking at this bits and pieces over the last few years. And so this year on this trip, we honed in on the environment to non-communicable disease or chronic disease connection. And through our partnership with your office, with the Institute of Water and Health, with our collaborators in the School of Medical Sciences at KNUST, as well as the School of Public Health at KNUST, and the Bettye Health Directorate, Bettye Municipal Health Directorate, we were able to focus more specifically on heavy metal exposure through mining occupations, and how that may or may not, we're looking at the data still, right, may not shape chronic conditions within those affected populations. I am excited as we dig deeper into that data to be able to share, disseminate these findings to inform practice, to inform research, and most importantly, to inform policy as well.
Absolutely. No, it was a wonderful trip. I mean, again, from the Institute of Water and Health. Dr. Aslan and I were sort of focused on the heavy metals and the soil and sediment, also working its way into the surface waters, but then to see the health team looking at hypertension and chronic disease and those kinds of things, it was amazing. And I might just say, for folks who have not been to Ghana, the warmth and observing the faith of those communities. We would say a prayer over every meal. And my goodness, the jollof rice. I can't even begin to tell you the jollof rice was amazing, sort of spicy, and I really, really enjoyed that. It was just fantastic. So
that is wonderful.
So your recent work, in addition to the project in Ghana, touches on Medicaid managed care organizations and social determinants of health. How do these larger forces shape outcomes for patients, especially in underserved communities?
Oh, yes. That was a really insightful study. It was funded by the Robert Wood Johnson Foundation, with Dr. Opoku kind of leading our Senate team to complete this study. And basically what we did is we interviewed several Medicaid managed care health plans across the nation. We really had a broad representation of health plans. And we tried to understand how and why they were addressing social needs for Medicaid enrollees specifically. And our findings really just confirmed or reiterated something that public health we've been espousing for years, which is the fact that contextual factors, including where we live, where we work, where we play, the factors that shape our experiences, our day-to-day experiences, such as poverty, such as access to healthy food options, such as access to other health-promoting options, like even transportation, like to be able to go to medical places, medical services. All of those things shape, in a negative way, if they're missing, our healthcare utilization, as well as our healthcare outcomes. And so it is important to look at health and wellness really from a whole person perspective. And thankfully, our findings suggest that the Medicaid managed care organizations acknowledge this, and they understand the importance of kind of integrating this social need perspective into the existing medical paradigm through which they operate. And so that was definitely reassuring, and it was one that was really helpful to inform the ongoing policy, even at a national level, concerning how to holistically improve the health and well-being of Americans, particularly those that are socially vulnerable and underserved as well.
And I think it's really fascinating also to consider how those policy implications take hold in America versus other countries.
Absolutely.
Because we hear a lot about this politically, right? I mean, other countries in Europe or other parts of the world, they have a different sort of social medicine system. And so really interesting to study those kinds of things. So, So looking ahead, what questions are driving your work right now today? What keeps you up at night, or what keeps you inspired?
Yes. I would say that really I've committed my career to trying to understand the healthcare system. And if you know how complex the U.S. healthcare system is, you can see how that would keep me up at night, right? Because of all the complexities. But currently, our team, Health Services and Systems Research Team, via the Center at our College of Public Health, we're really looking to understand some of the best practices for enhancing financial and operational improvement of health systems, with a bit of more of a focus on rural health systems. But most importantly, we're trying to look at how different factors, whether it's structural factors, process factors, how those things intersect, augment, or diminish one another in shaping outcomes at the organizational level, at the patient level, and at the community level. We are excited about just the opportunity to keep contributing to research and policy and practice in this space. And it certainly keeps us busy.
Sure, absolutely, absolutely. I've got to share with you just a brief story. When we had the opportunity to live in Romania years ago, this was maybe 10 or 15 years ago, our daughter took ill. She had a cold or something. And so we asked some of the other parents, like, who do we need to take her to? Which doctor? And so, well, you need to call Dr. Flavio. So we called Dr. Flavio, and he actually came to our residence with his little medical bag. And, did the full workup on our daughter, gave her the script. These are the medications you need. And it was $25 for a house call. I just could not believe that, right? So we have a very advanced healthcare system in the United States, but I think we can learn a lot from other
It
parts of
operates
the
a
world.
little
So,
differently.
absolutely. It really does. It really
Yes.
does. It's incredible.
Yes.
So, well, as we sort of wrap up today, tell our listeners one interesting fact about you that they would not know simply from reading your research.
I don't know if this is interesting, but I will say I'm a tad bit of a creative.
Okay.
I love to draw.
Okay.
I love to double in graphic design.
Okay.
But I will warn you that I'm still an amateur. So
That's okay. Hey, everybody's got to have hobbies. I mean, that's fantastic.
Yes.
Oh, I'll look forward to seeing some of your work sometime. It's fantastic. And finally, if you had to sum up your research philosophy, the route that connects all of your projects, what would it be?
Oh, philosophy. Yes. Community engagement is a big thing. In a lot of what we do, we're really looking to improve population health and health of communities. And it is important that we do not do things for people, for communities, but we do things with people and with communities. So that really is a strong principle that I personally operate on, and I've been lucky to be blessed with team members that strongly believe and adhere to this principle as well. So it has really served as a good undertone for a lot of the projects that we do, and really how we view health problems and how we view approaches to finding solutions to those health problems.
Partnership. That's
Absolutely.
It sounds cliche, but they always say teamwork makes the dream work,
Absolutely.
right? It really does.
Yes.
So, Bettye, thank you so much for joining us today. We really appreciate you stopping by to share all your great information, your wonderful research, and just everything you're doing positive for our community with our listeners. Thank you so much for being here.
Thank you for having me.
Thanks to our listeners for joining the Roots of Research podcast. And until next time, I'm David Weindorf. Hail Southern.
Hail Southern.